They may be more likely to present electively rather than emergently and have a greater outcome than those with limited access to care. Our study was limited in the fact that this was a cohort seen in an integrated health center in an urban setting with a Midwest geographic location, which may not be nationally generalizable. Thank you for the opportunity to present our work. I'm happy to answer any questions.
This very nice paper is open for questions.
Morning. Were you able to differentiate between patients with and without ostomates?
That was something that we looked at, and SVI, although it did confer increased risk of some comorbidities, I don't believe that it conferred an increased risk of having an ostomy.
So one just random thought. Yesterday, there was a lot of talk about sort of in the COVID time and the non-COVID time, and this is all pre-COVID. I wonder if it would become even more disparate in the COVID era. Anyway, just something to think about, but I agree. Very nice job.
Yeah, thank you.
Quick question. I was just wondering, how much do you think this presentation is just related to access to colonoscopy preoperatively?
Yeah, sure. I think that, access to care in general is probably the more inciting factor or inciting factor behind these poor outcomes. And anytime you have poor access to care, which is most likely the problem in these high SVI or more socially disparate groups, is they don't have access to care. So it could be that the presentation is emergent and they have to have an open operation, or they come in with already having perforation, have an infected wound already, et cetera, et cetera. Or it could be that they just don't have access to things like colonoscopy, screening tests, and therefore cancer presents at a later stage rather than an earlier stage.
Great. I have a question as your neighbor to the south. What is the SVI? Does it also include primary or preferred language and insurance status?
It includes 4 kind of groups or motifs, and one of them is kind of primary language status. And that is, is English your first or second language is one of the individualized questions within one of those 4 motifs. So yes, that is the target. Specifically, insurance status is not included. It wasn't originally used as a kind of medical tool. Again, it was used for like disaster mitigation efforts. For example, like if a hurricane were to affect an area like what's going on in Louisiana right now, they could use national sources or resources to kind of target the most disparate areas to kind of provide relief efforts. So it's just now being adopted into the medical field.
Gotcha. Thank you.
Yeah.
Wonderful. Thank you very much.
Great job. All right, our next paper is entitled Effective Perioperative NSAID Exposure on Anastomotic Leak Rate in Colorectal Surgery Patients, and it's from Dr. Yulia Kostenko. Am I saying that right?
Yes.
Okay, from St. Joe's in Denver.
Thank you. We don't have any relevant disclosures. Anastomotic leaks in colorectal surgery patients have a significant impact on patients' morbidity, mortality, and healthcare cost, and there are potentially preventable complications. Analyzing our National Surgical Quality Improvement database, we noted increase in anastomotic leak rates that interestingly coincided with our adaptation of ERAS. ERAS are patient-centered, evidence-based pathways that aim to improve postoperative recovery and facilitate improvement in physiological functions. NSAIDs represent a key component of ERAS. NSAIDs are potent analgesics that have opioid-sparing effect that's so important in our colorectal surgery patients. However, NSAIDs have also been implicated in poor wound healing that can affect anastomotic leaks. So the aim of this study was to analyze perioperative NSAID exposure and their effect on anastomotic leak rate at our institution. This was a retrospective cohort study looking at the NISCUB database specific to our hospital analyzing 2018 and 2018 patients undergoing colorectal surgery. The patients included in the study had either colonic or rectal resection with the primary anastomosis. It included 298 patients, and it was a mixture of elective and emergent cases. We broke those groups down into those exposed to NSAIDs and not exposed to NSAIDs. And then furthermore, we compared them based on their incidence of anastomotic leaks. The total anastomotic leak rate was 4.7%, and then broken down by their exposure to NSAIDs. It was 5% among the exposed to NSAID and 3.4% among those not exposed to NSAIDs. However, when we compared for statistical significance, the association between NSAID exposure and anastomotic leak rate was not found to be statistically significant. We also looked at the number of NSAID doses the patient received in the perioperative period. And calling our high dose number is at least 5 doses or more. That also did not seem to have an effect on anastomotic leak rate. Further, we broke down NSAIDs on based on their nature as COX-2 selective inhibitor such as celecoxib versus non-selective COX-2 inhibitors such as ketorolac and ibuprofen. Those medications also have been implicated in poor wound healing. However, those medications do not seem to affect anastomotic leak rate when looking at their nature. Furthermore, there was no statistically significant association between patient's age, gender, diagnosis, steroid use, bowel prep, perioperative radiation, elective or emergent nature of surgery in our study. In conclusion, the perioperative use of NSAID, including COX-2 selective and non-selective NSAIDs in colorectal surgery, had no independent impact on postoperative rate of anastomotic leaks. And we'll continue to use NSAID as part of our ERAS protocol until further data becomes available. Thank you. I'll take any questions.
Great job. So it's open for discussion.
Thank you for the talk. This has been going back for the past 10 years. The data on NSAID, Toradol and ketorolac or NSAID has been on either side of the fence. They have data showing whether it increases anastomotic leak. For a while, all of us colorectal surgeons avoided using it. And then there was another big meta-analysis that said, oh, it's not too bad. You could go back and use it. The problem with studying something like this is your endpoint is such a, it's such a rarity, right? Having an anastomotic leak is, you said 5% or less, so, and it has so many confounding factors. So if you really want to study it and break it down by dosage and everything, unfortunately, you need a larger number of patients because your endpoint is such a, so it's, I think it's hard to draw any major conclusions. It's a power thing with this. But I think that I still use NSAID. The jury's, it's because I'd rather that than then get constipated and ileus for 3 days,
Yes, thank you. So that was a quality improvement project specific at our institution. We wanted to look whether it has any effect, and it didn't, and we still continue to use that. And magically, the anastomotic leak rate decreased as soon as we started looking at that.
I have one quick, oh, sorry, go ahead.
I was just wondering whether or not you looked at the type of colon resection, right, left, sigmoid, low rectal, just because that would have an impact on your leak rate.
We didn't, and that's a great question. I think our sample size was relatively small. It was about 300 patients, and they were also elective and emergent cases. And we didn't break them down based on resection. I think if we had a bigger sample, that would be a great study to look at.
So my question is, of the cohort that didn't get the NSAIDs, why? Why didn't they get it? Was it a surgeon A or B doesn't use NSAIDs or this sort of thing? Or were there patient factors that, like advanced renal disease or such that prevented you, or do you even know? I don't know.
Yeah, so at St. Joseph Hospital, we have several group of people that have different preferences. Some surgeons feel strongly about not using NSAIDs, and some surgeons click on the ERAS protocol when they have colorectal surgery, and that drives them to give patient NSAIDs. So I think it's largely driven by surgeon and their preferences.
Yeah. Well, if the surgeons didn't have preferences, you wouldn't have been able to do this study, but it was-
Exactly.
So great job. Really great job.
Thank you.
Yep.
Our next paper, presented by Kimberly Oka is bilateral gluteofasciocutaneous advancement flaps with and without tie-over sutures in the treatment of pilonidal disease from the group at Cedars-Sinai.
Good morning. My name is Kim Oka, and I am an undergraduate student working with Dr. Yosef Nasseri at Surgery Group of Los Angeles, which is based at Cedars-Sinai Medical Center. First, I'd like to thank the Congress for the honor of presenting. And today I will be discussing our study, bilateral gluteal fasciocutaneous advancement flaps with and without tie-over sutures in the treatment of pilonidal disease. We have no disclosures. Pilonidal disease is an inflammatory condition of the sacrococcygeal region, afflicting up to almost 1% of the general population, and is most common among young males. Several predispositions for the disease include excess hair, obesity, and a deep natal cleft. One proposed etiology for the disease is hair with chisel-like roots falling into the natal cleft, leading to a foreign body tissue reaction. Treatment for pilonidal disease is challenging, mostly due to high dehiscence and recurrence rates. So when primary treatments like incision and drainage fail, or patients have recurrent pilonidal disease, off-midline flap procedures are commonly employed. And although these procedures offer relatively low dehiscence and recurrence rates, they do come at a cost of poor cosmesis, need for hospitalization, and prolonged healing. Therefore, the ideal repair should be simple and easily transferable to other physicians, have a low dehiscence and recurrence rate, is an outpatient surgery that requires no hospital stay, allow for a quick return to normal activity and work, and have good cosmesis. Our study is a prospective case series of 51 patients. Here is a stepwise description of our technique. So first, the sinus tract is identified with a fistula probe, and the sinus tract cavity borders are marked. Next, an elliptical incision is made and carried down to the pericoccygeal fascia, eliminating all involved tissue. After that, the post-excision wound is reconstructed by elevating the bilateral fasciocutaneous flap. And they do that in a 360-degree manner with a blunt discontinuous dissection. After that, a multi-layer closure with 2O vicryl is performed, followed by a horizontal mattress skin closure with 3O monocryl. In our last 35 patients, in an effort to lower the dehiscence rate, we also placed 2 full thickness compressing sutures tied over rolled up gauze, which is shown in panel F right here. And panel G is the resultant midline scar. Here are our results. In our cohort of 51 patients, the mean age was 28. It was predominantly male, and the mean follow-up was around 3.5 years. 16% were smokers, 22 were obese, and the mean operative time was around 1 hour. Our overall dehiscence rate was 37%, and there was no recurrence in our series. In a sub-analysis comparing patients with tie-over sutures and without tie-over sutures, we found no significant differences other than a trend towards lower dehiscence in patients with tie-over sutures. Analysis on relevant comorbidities revealed that obese patients with tie-over sutures had significantly less dehiscence compared to obese patients without tie-over sutures. As for the cosmesis, we have here a comparison of the final suture line. Panel A is our technique. It results in a midline scar that recreates the natural gluteal cleft in comparison to the Limburg flap, the Karadakis procedure, the Bascom cleft lift, the VY flap, and the Z-plasty. In conclusion, bilateral gluteal fasciocutaneous advancement flap with the consideration of tie-over sutures, especially in obese patients, is an effective outpatient treatment for recurrent pilonidal disease with a resultant midline scar and no recurrence in our series. Thank you again for the Congress for allowing me to present this study, and I'm open for any questions.
Thank you very much. This paper is open for discussion, and I guess maybe I would start with a question. Can you talk about what the activity restrictions are following this procedure and whether that adherence or not may have also contributed to the dehiscence?
Thank you for the question. For that, I'll actually defer to my PI. I think he can better answer the question.
Great job, Kim. So you're right. The post-operative care is as important as the surgery, which has emphasized to the patients. First 48 hours, I tell them don't sit, don't even sit down. You know, you sit on, lay on the side or walk around. After that, they sit on a lot of fluffy, cushiony stuff, and I tell them offload every 30 minutes to 45 minutes. And then they come to the office about 5 days out, and I remove those retention sutures. Even then, I'm telling them, be a potato couch for God's sake.
Yeah, thank you.
So I have two comments. One, pilonidal disease is a challenge, and the fact that you are taking it on is wonderful. I think this makes a lot of sense, and you've done some great work. But I think more importantly, Kim, I just want to tell you that as an undergraduate student, I gave my first talk about some things that I wasn't super sure of, and I'm certain you did a much better job today than I did many years ago. So congratulations, really great job.
Awesome. Thank you for that, Peter. Thank you.
All right, number 5, the impact of the COVID-19 pandemic on colorectal cancer care in an underserved community along the United States-Mexican border. And this will be presented by another undergraduate student, graduate, Mariah Hamdan. Welcome.
Hi, thank you.
And from Texas Tech.
Yeah.
All right, let's do it.
Good morning, everyone. Thank you for having me here. This is my presentation, and so I do not have any disclosures. So colorectal cancer is one of the leading causes of cancer deaths in the US, which has been majorly prevented by colonoscopies. And however, the COVID pandemic has led to a halt in screening colonoscopies with an 84% reduction in screening and a corresponding 54% reduction in new cancer incidence. And these delays are associated with a significant increase in both mortality and advanced stage tumors. And while there are national studies that studied the effect of the COVID pandemic on colorectal cancer in the US and in Europe, there's no data on the effect of the pandemic on colorectal cancer care, specifically on underserved areas on the US-Mexico border. And Hispanic communities in El Paso, Texas, are often underinsured, have an unreliable access to primary care with lower screening rates in relation to their white or African-American counterparts. So we aim to understand the effects of the pandemic on colorectal cancer in underserved populations on the US-Mexico borders, where they already have lower screening rates and higher cancer incidence than national averages. So we did a retrospective chart review using our own statistical databases, using ICD-10 codes 18 through 20, specifically assessing for the number of patients with newly diagnosed colon cancer, rectum, sigmoid, or rectum, correspondingly, And then the cancer stage of presentation, if they presented initially at the ED or the office, like through screening colonoscopies, if they were treated, and the number of oncology and surgery clinic visits. We did exclude patients under the age of 18, patients who, after reviewing their chart, did not have any cancer, patients who had anal cancer, as it usually treated with chemoradiation rather than surgery, and then patients with previous diagnosis of colorectal cancer, like prior to 2019 or 2020, and patients who were diagnosed at a different facility, like who were private patients, and we had incomplete access to their records. We used descriptive statistics and odds ratio. And so here you can see the total number of patients. And we had a 25% reduction in the amount of patients with newly diagnosed cancer. And you can see here, we had many patients who initially did not have colon cancer, or and they were had a prior diagnosis. And so when stratifying by stage, we actually had a 12% increase in the amount of people who presented with metastatic disease at presentation in 2020 as compared to 2019. And then when looking specifically by the location of initial presentation, about 70% of patients presented to the ED in 2020 with advanced stage cancer, as opposed to only 62% in 2019, which both, and you can see here our ED presentation rate is 59 and 69% is already very high. Patients were 1.5 times more likely to present at the ED in 2020 as opposed to 2019. Patients were also less likely to receive overall treatment in 2020 as opposed to 2019. And then our surgical clinic visits decreased by 37%, while oncology clinic visits only decreased by 7%, owing to a large number of them being virtual. So in here we saw that our colorectal cancer incidence rate in El Paso is comparable to that of the US. However, we do have lower screening rates than US averages, which means a lot of people have colon cancer, just they're underdiagnosed. And we had more patients presenting with advanced stage cancer, like metastatic cancer in 2020. And we do have higher ED presentation rates than previously reported in the literature, which associated with increased surgical morbidity, length of stay, mortality, as well as increased costs for the society, as well as the hospital systems. So it is limited by using ICD-10 codes. Billing coding data is usually inconsistent and provides sometimes inaccurate diagnoses. And while we did comb through the data to find these, we looked at patients' charts to identify the specific information we're looking for. In the future, developing a patient database where patients diagnosed with cancer can be uploaded into the system and then tracked, and that will provide better care comparable to the optimal care pathway timeline. So in conclusion, we do have a high number of patients who initially presented the ED with advanced cancer. Patients were less likely to be treated during the pandemic, and implementing an FOBT screening system that could be mailed to patients when followed up on if they're positive, along with having a database for patients with colorectal cancer may allow for earlier treatment and diagnosis and allow for timely care and treatment. Thank you.
Wonderful job. Good job. So yeah, we're open for discussion. I have one, comment or question. So in the COVID, the initial COVID era, where everything kind of shut down, all sorts of procedures and operations were put on hold or canceled. Then we had a restart and then another drop, and we're into the third surge. Are you seeing in Texas again a shutdown of elective colonoscopies and things? Is this going to just just going to be a cyclical problem, or do you see that you're now able to better navigate through this, or do you even know? And this may be sort of outside of your purview. I don't know.
So I started my surgical internship at Allentown, so I moved away from Texas, but I do expect that we would have better ability to understand which patients could have higher priority for screening, depending on their symptoms, and rather than before where everything was completely shut down.
Right. Great. Well, thank you.
If Yeah, thanks so much. I am in New Mexico, as you know, and so we see the same population. If they don't get to El Paso, they make it to Albuquerque. And so we have definitely seen the same thing. I had one question when you said that they didn't receive treatment, given that there was a significant percentage that were metastatic, those are patients that may or may not have needed any surgical intervention. Can you talk about which treatments were or were not received that should have been received, if that makes sense?
Yeah, so how did I go back? Okay, so we actually, 2020, we saw overall decreased treatment with both modalities, like, because we stratified them by like people who got chemotherapy versus people who got surgery versus people who got both. We saw less number of people got both treatments. However, like not statistically significantly, but more people had surgery, which could be accounted for in metastatic cancer, like asymptomatic.
Right. Yeah, unfortunately, there, if you're bleeding or perforated, that's how you get your cancer diagnosed these days, which is really unfortunate. So, great. Thank you very much. Great talk. Our next paper is the adoption in indocyanine green fluorescence angiography as quality improvement in colorectal cancer, presented by Dr. Wilson and the group at St. Joseph's in Denver.
Good morning, everyone. Thank you for having me. My name is Lexi, and I'm a fourth-year surgery resident at St. Joe's. So as many of you know, adequate bowel perfusion is a key element in anastomotic integrity and a reduction in anastomotic leak. Indocyanine green fluorescence angiography is a valuable tool at the surgeon's disposal to actually evaluate the bowel in real time and look at the perfusion. My interest, or our interest in this project, actually first came about when I was an intern and attended a conference and learned about ICG fluorescence angiography, and I was very excited about this new technology. So went back to our hospital and was asking around if anyone had used it. Not many people were using this technology, and we went back and looked at our NISQIP data and found that less than 5% of colonic anastomoses were evaluated using ICG fluorescence angiography, which is what prompted this quality improvement project. So the goal was to increase our use of ICG fluorescence angiography, as well as the hopeful long-term goal of decreasing anastomotic leak rates. So how this project started, we started first with a couple educational sessions, both to residents introducing the technology, as well as to the OR staff. And then we did a grand round to the attendings to try to persuade them to adopt this new technology, which you can imagine was challenging at times. We then, after these educational sessions, created a survey and asked those that used ICG fluorescence angiography if it did change their intraoperative surgical management and if they would use it more frequently, and whether or not it changed their operative, if it was used and if it caused a change in their management. So then we reviewed our NISQIP data if they did not perform the survey to see if it was used or not, and if it did change their management. So this was a retrospective chart review from August 2019 to September 2020 using both the survey and NISQIP data. So the results, this was a 12-month survey period, and after our project, the ICG use increased from 6% to 51%, and surveys were completed in about 52% of cases. And 82% of survey respondents said that they would use fluorescence angiography more frequently or routinely in the future. And 6%, 4 out of 65 of those that use it reported that it did result in a change in their management, and there was 4 revisions of anastomoses. However, we noted that after the survey and our project completed, the use of ICG did drop almost 40%. So this was a prompt to us that we need continued education and encouragement of using this new technology, or not new. And then when looking at the leak rates, we did find no statistically significant decrease or change with the leak rates when using ICG versus not, but we did see that, of our studies, 5%, there was a 5% leak rate with ICG versus 2% without ICG. But from our experience, those that used ICG fluorescence angiography, it was more of a selective use and it was biased. Most people that used it were concerned about their anastomosis to begin with, so hard to draw any conclusions from there. So, oops. In conclusion, this quality improvement project was successfully implemented and increased the use and influenced clinical practice at our institution. But due to the small sample size, we're unable to draw any conclusions about the anastomotic leak rate with using ICG versus not. But by implementing this new technology, it's now being used in many implications at St. Joe's, which include cholecystectomies and lymph mapping. And in conclusion, further studies are needed to survey the ICG use, and overall anastomotic leak rates will need a large randomized controlled trial for that. So that I'll take any questions. Thank you.
Really nicely presented, interesting paper. So,
Thank you.
yes.
Great study. So the whole ICG thing, as you know, is been used. It's all over robotics now, right? Gallbladder
Yeah.
disease, etc. It's such an easy thing to do. Also, you just give within less than 1 minute. It goes, you know, the anesthesiologist gives it.
Yep.
So I think that ultimately the result will pan out, that it makes a difference, but you have to have a lot of patients that ultimately do. There have been previous studies in the laparoscopic era using the same technology with and without, and that showed that it does decrease some leak rate. And I think the data will ultimately, you know, pan itself out in colorectal surgery.
Mhm.
So I think it's, you know, just a comment, such an easy thing to do.
Yeah.
And
We thought
ultimately,
so too, but that's the hardest thing, is convincing our attendings that it's very easy, quick. So
and if
we
you make it
agree.
as a part of the routine, that takes an extra 30 seconds. Ultimately, it will make a difference in that 1 or 2 patients, you know?
Yeah, agreed.
Yeah,
Thank you.
great job.
Thank you very much.
All right, so the next paper is multi-specialty outcomes and the role for surgeons in anus squamous cell carcinoma patients at an independent academic medical center. And this is being presented by Dr. Richard Cutts from Gunderson Health.
Thank you. I want to thank the Southwest Surgical Congress Committee for accepting this abstract and allowing me to present here today. We have no disclosures. As we're all familiar as general surgeons, anal squamous cell carcinoma is not one of the most common cancers we deal with. Despite this, you can see the incidence over the last 20 years has steadily increased. In past historical context, abdominal peritoneal resections was often used to treat this cancer. And as we know, does not come without risks and does have lifelong morbidities as well as lifestyle changes. In the early 1970s, the treatment paradigm for anal squamous cell carcinoma was shifted from surgery as the primary option to chemoradiation as the primary option after a publication by Dr. Nigro. Our study aimed to compare our survival rates at our independent academic center to that of the national data and to show the continued vital role that surgeons play in the treatment management of anal squamous cell carcinoma, despite surgery no longer being the primary treatment. Our study was IRB approved and identified anal squamous cell carcinoma patients from 2005 to 2017. Outcomes of interest that we looked at included mortality as well as surgery. And our national data was obtained from the surveillance, epidemiology, and end results or SEER database, and we use that to then compare to our own data. The SEER database has been around since the early 1970s and gathers cancer data throughout the United States. An interesting fact is it's the only comprehensive cancer source in the United States that has the stage of the cancer at the time of diagnosis, as well as the survival data. As you can see from this table, the majority of our patients were female, 73%. Most were in the 7th decade of life and were overweight. 71% had a current or history of tobacco use, and interestingly, only 12% had any HPV documented in their chart. Most patients who were diagnosed with anal squamous cell carcinoma in our study came in at an advanced stage. 88% were either in stage 2 or 3, indicating that their tumor was greater than 2 centimeters. They had nodal involvement or both at the time of diagnosis. More than 70%, so the majority of patients were treated appropriately with NCCN guidelines in the NIGRO protocol with undergoing chemoradiation as their initial treatment. Of those, 20% went on to have subsequent surgeries. A little under 20% were initially treated with surgery, 2 of those being APRs, one for a concomitant vulvar cancer and the other for a patient who had previously been treated for prostate cancer and had already undergone radiation therapy, making him not eligible for chemoradiation therapy. The 7 local excisions, looking at their preoperative diagnosis, it was for either symptomatic anal masses or symptomatic hemorrhoids. Of those local excisions, 1 went on to further need surgery and an APR performed. Less than 10% had radiation as their initial treatment, with 1 of those going on for an APR for recurrence. Of note, if you look at all the patients that did end up going to the OR in our group, 35% of those patients in our study needed the OR. An average of 3.3 endoscopies were performed per patient during the surveillance follow-up period. And of all patients treated, just over 2/3 went into remission and experienced no recurrence of their disease. About 12% went into remission, but experienced recurrence of their disease, and about 1/5 of patients experienced never went into remission. This table compares our data at our center to the national data. And although some of those numbers at the 5-year do seem significant, after statistical analysis, there was no statistical significance appreciated. Our study does have limitations. Multiple providers were included in this study, and we cannot control for the innate bias of each provider. This was a retrospective study and was performed at a single health system. With that came lower numbers, and with that lower power for our statistical analysis. There is incomplete data, as at the initial portion of our study time period, we were still transitioning from paper charts. And there was practice changes over the study term, with NCCN guidelines first being introduced in the early 2000s, and that slowly being adopted by the providers. In conclusion, the majority of patients with anal squamous cell carcinoma were treated appropriately with chemoradiation therapy. We noted that the survival rates at our center were comparable to that of the national data, and the important role that surgeons play in the treatment of anal squamous cell carcinoma remains. As mentioned before, 35 patients ended up going to the OR at some point. If you include those who were seen by surgeons either in diagnosis or surveillance, that number increases to 65% of the patients. Thank you.
Great job. This is open for discussion.
I have a question. So can you talk about how anal cancer patients get, how they access your system? Is the primary referral to a medical oncologist to begin with, to the surgeon? Does it come from the gastroenterologist?
Yeah, no. So it comes from a lot of different places. Some of it's the primary care providers. Sometimes it's the GI doctors who they have this anal issue. They go see the GI doctor. Sometimes it's on a colonoscopy that then they notice this lesion of the anus or in the anal canal. And then sometimes it's, a lot of times the primary care providers, they notice that someone's having an issue with their anal canal and they're like, well, let's send it to a general surgeon. And then we take a look at it.
In your system, what about your HIV population? Is there, I know we have a colorectal surgeon in our group that's basically stationed at the HIV or what we call the Truman Clinic in New Mexico, just for that reason, so that they do have a close surveillance for those that may go on from high-grade dysplasia to invasive carcinoma, so that it doesn't get blown off.
Yeah, and reading the literature, I know HIV is very associated with this cancer. In our population, HIV is very low prevalence of that. And we did look at that in our study, and it just wasn't a high enough prevalence to our current population.
Yeah. And what is you said there were a little over 3 surveillance anoscopies. What is the schedule that you usually put those patients on?
Yeah, so for the first couple of years, it's normally about every 4 to 6 months they'll see someone. Sometimes it's a general surgeon, sometimes, most of the time it is, but sometimes it's a general surgeon in an outlying area. And so they'll come see us and for diagnosis, and if they have surgery, they'll see us. And then a lot of times we'll try to get those patients back to either their general surgeon in the area or a GI doctor in the area who can do those as well.
Right. Any other questions for this paper? Wonderful. Excellent. Thank you so much. Next, we'll hear about longer hospital length of stays associated with higher in-hospital mortality of patients admitted emergently for colon cancer. This is analysis of over 19,000 patients from I guess student physician, hopefully, NAF, from Westchester Medical Center.
Thank you. Yeah, good morning. My name is Hari Nath. I'm a 4th-year medical student at New York Medical College. I'll be presenting about longer hospital length of stay is associated with higher in-hospital mortality of patients admitted emergently for colon cancer. analyzing 19,231 patients. I want to thank the scientific committee for this opportunity to present and my mentors for their guidance and support. We aim to assess the independent predictors of in-hospital mortality of non-elderly adult patients with complicated colon cancer requiring emergency admission. Complications included things like hemorrhage, perforation, or obstruction. And we looked at previously described independent factors that were associated with adverse outcomes. So those were emergency versus elective admission status, patient's age, and patient's health status overall. This is a retrospective cohort study using the National Inpatient Survey from 2005 to 2014. And we looked at 19,231 patients. Our inclusion criteria was age of 18 to 64 years, a diagnosis of malignant neoplasm of the colon, and the patient requiring emergency general surgery. Our primary independent variable was hospital length of stay, and our dependent variable was in-hospital mortality. The statistical analysis that we used was generalized additive model, or GAM. So the mean age of our patients was 53.5 years, with a differential from survived versus deceased groupings of 53.4 years versus 56 years. We had 46% of our patients as female, 60% white, 20% Black, and an overall mortality rate of 2.6%. The hospital length of stay was 10 days on average, with again a differential with survived versus deceased groupings, 9.9 days for those who survived, and 15 days for the deceased group. So multivariable generalized additive model was used to describe the complex relationships between mortality and age. Effective degrees of freedom, EDF, is used to describe the nonlinearity, and EDF of 1 is a linear relationship, and greater than that is the degree of nonlinearity. So here we show that the association of mortality and age is indeed a left skewed U-shaped association, with the lowest mortality in the middle group of 35 to 49 years. And the table shows the mortality rates for the 3 age breakdowns, 18 to 34, 35 to 49, and 56 to 64 years, with the middle group having the lowest mortality for both sexes. So again, with multivariable generalized additive model, we showed a right skewed U-shaped association between hospital length of stay and mortality. And we show that the 5 to 14-day range is the length of stay associated with the lowest mortality rates. And specifically, day 9 is the nadir. And we show an ascending portion of that relationship from day 9. We further analyzed with multivariable logistic regression and found a 1.035 as an odds ratio, showing us that for each day after day 9 in the hospital, there's a 3.5% increased risk of mortality. We looked at 29 total comorbidities in the study, and here this table shows the comorbidities that were associated with an increased odds of mortality and their 95% confidence intervals for odds ratios. This was using the generalized additive model from the previous slide. So this was a subgroup analysis of those patients who had no comorbidities reported. So when we look at this, we see a pattern mirroring that of the overall analysis, a U-shaped association with hospital length of stay and mortality. And specifically, the difference here is a 5 to 10 day range was associated with the lowest mortality. So in conclusion, when we see this mortality benefit for the middle of the pack in age group, we wondered why. So some options are the behavioral malignancy, could be more aggressive in the younger patients, and perioperative risks and complications are higher in older patients. So this might just represent a trade-off optimization for that middle group. And the right skewed U-shaped association for hospital length of stay, we show the 5 to 14 day being that range, which was the lowest in mortality. So again, with that linear relationship near linear relationship we showed after day 9, that 3.5% increase per day motivates one to find more ways to optimize patient stays to that length. Whether or not hospital length of stay is an independent risk factor, requires further studies, but regardless, it shows us a clinical opportunity. Thank you.
This really interesting paper is open for discussion, and I guess maybe while somebody comes to the mic, so length of stay is a complex factor. Obviously, there's a lot of things that go into it. I'm wondering kind of what you postulate in addition to just you're sicker and it takes longer to recover from emergency surgery. Any other factors that you think may have contributed to that?
Yeah, so longer length of stays, you can kind of every day you invite the opportunity for hospital acquired infections. And again, like you said, there's just the general, if you have a very sick patient, they usually require longer care. And then the very short stays can also just be associated with patients that didn't respond to the treatment and unfortunately succumbed.
Yeah. Question at the mic. Thank you.
That may have addressed my question, but I was surprised to see the high mortality rate in patients with very low length of stay. And I was wondering whether that was driven by patients who died shortly after surgery.
Yeah, that would be the cause of death for all of the patients. That's something that we would like to look further into, but because these patients have their comorbidities and have all the reasons before they present, there's just different risk values. But yes, that would be the assumption, is just that they didn't kind of take to the treatment, for lack of a better term.
Be interesting to rerun that analysis, looking only at patients discharged to home, and then seeing whether or not that early association with length of stay and mortality disappears.
We
Thank
did.
you.
We looked at the disposition of the patients, either home PT, rehab, inpatient rehab, et cetera. And in fact, one of the things that I think would be an interesting thing to see is what they came in with, like if they were already functional status limited for whatever else reason, to see if there is a comparison there. But that is definitely an opportunity for us to look further into it. Thank you.
Great. Excellent.
Good job. All right, our final talk today is entitled Extent of Hepatectomy for Gallbladder Cancer, Less is More? Question mark, by Sharon Joseph from Texas Tech.
Hi, my name is Sharon Joseph, and I am a surgical intern at University of Iowa. And I want to thank the Surgical Conference, Southwest Surgical Congress, for allowing me to have this opportunity to talk about an abstract that we submitted as a medical student from Texas Tech, El Paso, entitled "An Extent of Hepatectomy for Gallbladder Cancer, Less is More." We have no financial disclosures. So gallbladder cancer is a very common biliary cancer with a very poor prognosis, with about a less than 5% 5-year survival rate. Often patients are asymptomatic at time of diagnosis and often found to have this diagnosis after a lap cholecystectomy. Right now, our current understanding is to have the best outcomes, we need to get an R0 resection. So having a radical resection with about at least 6 nodes is associated with improved survival. But what we don't know is how much of a hepatectomy is necessary, or how could that affect patient outcomes. So our aim was to try to decide and figure out what if a partial hepatectomy versus a lobectomy affects patients' outcomes. Also examining patient outcome based on T staging at the time of diagnosis, as well as conduct multivariate survival models. And so we looked at the National Cancer Database, NCDB, which is over 1,500 hospitals around the nation, looking at gallbladder adenocarcinoma and known hepatectomies diagnosed or seen between the years of 2010 to 2016. And we conducted, we were able to obtain about 1,300 patients for our study. And it was a retrospective database analysis. And we had about over 1,100 patients that underwent a partial hepatectomy, and about over 100 for those that had a lobectomy. And as you can see, our data is actually pretty well matched. You can see that they're very similar in the 2 groups in age, gender, race, ethnicity, comorbidities, and even tumor size. And as we further quantify the differences between the 2 groups, we can see that the lobectomy group tended to have a positive surgical margin, a higher T stage with T3 and T4, positive lymph nodes, poor tumor differentiation, and having no chemotherapy at the time. As expected, we did see an increased hospital length of stay of about 10 days in comparison to 7 in the partial hepatectomy group. We also saw an increased 30 and 90-day mortality rate in the lobectomy group, about like 3 to 5% higher in the lobectomy group. We then further quantified this by doing a multivariate system analysis, and we saw that even with that, we saw that the lobectomy group had a hazard ratio of 1.8% or 1.8. We also saw a few other factors that were also still positive after multivariate analysis, including higher comorbidities, surgical margin, higher T-stage, positive lymph nodes, and poor tumor differentiation. One positive predictor was chemotherapy use. It did tend to have a more favorable outcome. We did see that in our Kaplan-Meier curve that patients underwent a partial hepatectomy tended to have a longer median survival of 34 months after a resection compared to the lobectomy group of 18 months. Some limitations of this study is that it is a retrospective database analysis, and so we can have patient selection bias. We have no real detailed data on the type of chemotherapy used or exactly what was the hepatectomy done per data point. We also have our survival and comorbidity defined by outcome survival and the comorbidity index. So in conclusion, we see that the majority of patients that undergo hepatectomy do have a partial hepatectomy and that they have improved postoperative outcomes, having a shorter length of stay, as well as a lower 90-day mortality. And this survival benefit is even seen after adjusting for known predictors. And so with that, I'd like to open the floor for any questions.
Great job. So this is open for discussion. My question really stems from, is there just an inherent bias to the patients that are undergoing, an extended hepatectomy or lobectomy, because those patients likely have had post cholecystectomy, but pre-operative imaging to suggest that their burden of disease is higher, and therefore the operative necessity increases, and so these people are potentially set up to do poorly. So it would be interesting to look at what sort of drove the operative decision-making to get you to that extended operation versus just partial segment 4 or something.
Yeah,
Did you have any thoughts?
Yeah, I think it's the difference too between the incidental gallbladder cancer found during cholecystectomy as opposed to I had abdominal pain, I got my belly CT in the ED, my gallbladder looks funny, and then who did you go see in the first place? Were you sent to a general surgeon who did cholecystectomy, or did you see a surgical oncologist or an HPB surgeon who was looking at you, assuming that you had cancer, because that's what cancer doctors do. We assume everyone has cancer and needs a big whack.
But fair, and it would be very interesting to see like a prospective study of this and try to further quantify all of this. It was interesting that the tumor size was very similar between the two groups of like the partial hepatectomy group and the lobectomy group. So it would be interesting to see, what really drove the surgeons to decide their operative technique.
Yeah, there's a prospective study going on right now that Shishir Mittal at Emory is running on the incidental gallbladder cancer found. So I know UNM's part of that registry. It would be fascinating. It's really a rare disease, and it really does take a collective effort to be able to answer some of these questions. And I also think there are probably ethnic differences, again, reflecting our Native American population, which is going to look different than other populations.
Right. Thank you. Yeah.
Great job.
Yeah.
So did our first people, do they ever show? Okay. So we're 8 for 9, but thank you everyone. And to all the presenters, I think a great job. We have the OR lecture today at 8 o'clock, which is in 15 minutes. given by Dr. Laura Moore, and she has a very intriguing title, Blood, Balloons, and Blades, the Future of Trauma Resuscitation. So we invite you to take a break and
Yep.
see you then.
Great. Thanks for attending.